All right, so we're moving on to vasopressors. So we kind of talked about default orders, we kind of talked about vasopressors and shock states, but now we're going to be moving on to vasopressors. So we'll talk about the bee's knees. That's norepinephrine. That's our really go-to agent, right? They used to do a lot. They did a lot of research in the 90s and early 2000s, right? They said it had norepinephrine or Levophed, and they said, you know, Levophed, leave them dead. There's no reason to start Levophed, right? And everybody was on dopamine. They're like, shoo. Dopamine is the best. That's the one you want to be starting them on. That has great activity. Look at all that stuff it's doing. And they found out that it actually has worse outcomes and higher mortality. So and Levophed was actually the best one all along. All right. So Levophed is usually our go-to agent. That's one you're going to see a lot. And then we have phenylephrine, right? Phenylephrine has its own some good properties to it, but it's never usually our first or second choice. It's usually probably a third choice. There are some situations where it will be a first choice, as we'll find out. So when you have high heart rates, that's usually the time when you would start phenylephrine first. All right, epinephrine is good, but it's it's better than dopamine, but it does have good effects on contractility, for instance, of the heart. And we got vasopressin. That's our best bud to norepinephrine. That's the one that's those guys together, very synergistic. They're going to work great especially for septic shock, right? So the ICU and the ED is very optimistic, right? There's a lot of pressors we can add to a patient, right? We can add 2 pressors, 3 pressors, 4 pressors, 5 pressors. There's other ones out there like angiotensin 2 and methylene blue, and there's all kinds of other agents we could add, but again, there's futility and there's actually things that are actually have good outcomes. So as we know, when already you have like multi-organ failure, your risk of dying is already up to 60-80%, depending on which organs are involved. So we got to think about that when we are deciding to add more pressors, right? And pressors should be given through a central line, right? If you aren't putting a central line in, especially when you're on moderate dose Levophed, because usually the one we start first, right? Once you start hitting like 10 mics, again, it's 0 to 47 is our range. So if you're getting like 10 mics or higher, that's usually when you're starting to get a central line placed, right? And probably an arterial line as well. And usually 10 mics is when you're adding our best friend, vasopressin, as well. Okay, so otherwise, are you a dermatologist? Because it's going to extravasate and it's going to eat through the vessel wall lining, and it's going to cause a lot of deterioration of tissue and even amputation and gangrene. So we want to make sure that we have central access for that reason. At least if it's only like 4 or 6 mics, we maybe get away with it, especially if it's a good vein, right? And especially if it's ultrasound guide placed, then you could maybe get away with it overnight or for a shift or so. But if they aren't coming down with Levophed, they might need to have that placement done, right? So norepinephrine and pressors, usually our goal map is 65. 65 is where you want that's usually a good indication that we have good renal perfusion, good brain perfusion, good liver perfusion, good heart perfusion, right? And then what else? So if you're still getting hypotensive, we're going to start adding other pressors on. And what else can you add on? That depends on what the patient looks like. If they're in AFib RVR, adding on like epinephrine might not be a great choice, right? Dopamine is never a good choice, but you can, if you need to, sometimes we need to add more pressors. We have to figure out which is the right agent to add, because every agent has its own side effects. And to understand the side effects, you have to understand the receptors involved, right? So a lot of these guys are going to be working on the SNS, right? So our SNS is, works on the beta-1 receptors, alpha-1 receptors, beta-2 receptors. So you have to understand how these are interacting, right? And then, there's dopamine receptors, and there's vasopressin receptors, there's angiotensin 1 receptors. So all these things we're looking at for titrating of vasopressors. All right, so map of 65, that's where it's at, right? That indicates perfusion, right? You never titrate to a systolic or diastolic. That's never okay, right? It always needs to be a map, because as we mentioned, the NIBP cuff measures the map first, and then it estimates a systolic diastolic. So why titrate off an estimation? Titrate off the actual map. And same thing with arterial line. Arterial lines can be dampened or under-dampened, and that they can cause false systolic and diastolics. But the map is always accurate despite what value you have for systolic and diastolic, right? Lower maps might be acceptable, like a map of 60, map of 55 even, and a patient might be like a liver failure patient, or a chronic steroid user might have like a low blood pressure to begin with. If a history of hypertension, no, they should not be anything less than 65. You may even target like 75 or 70 for someone who has history of hypertension, because they are used to having a really high flow through their body, right? And they're used to that because they've been, having donuts done through hypertension throughout the years, and it's literally causing the vessels to hypertrophy throughout the body, right? Of course, the hypertrophy puts more SVR in the system, more afterload, puts more stress on the heart, and they get heart failure with preserved ejection fraction. But they're used to a higher flow at this point. Okay, so really 2 is all you need for pressors, right? There's some times where you might do more than 2, right? You might come in and say, oh, I saw the patient on 5 pressors. That's just because the nurses begged the provider overnight, or beg the provider to get more, because what else can we do? Or, there's family flying from Cuba, Mexico, Canada, and Guam. It's like, okay, we'll have to put more pressors to maintain that. But usually 2 is the max. And the time where you can say 2 is not the max is if they are younger, they don't have a lot of comorbidities, and you don't have the knees. Again with the knees, right? You don't have the knee modeling happening, right? If the knees are already modeled, you're done, right? You're not adding more pressors is not going to help, right? But if you don't have any sign of modeling and you still have some good perfusion by labs, we can start adding more pressors on to see if there's any kind of good outcome. When you do add a lot more pressors, it's called a salvage therapy, where you're salvaging like a 24-year-old, for instance, that had maybe a drowning episode, or they have a severe septic shock. Yeah, we're going to throw everything at them, right, to try to get that turned around. They had no other comorbidities. They weren't a 24-year-old with cerebral palsy and a suprapubic catheter and a stage 4 decubitus. These are 2 different patients, right? And it was not like we're choosing and playing God. We're looking at evidence and mortality and such. We're looking at who's going to have the better outcome, right? We can try it, sure, but it's going to have worse outcomes if we give more pressors. Remember that graph of the side effects versus the intended effect? So it's going to have a lot more side effects when you have a lot more comorbidities, right? And again, gut ischemia things are going to start clamping down. And the gut is one of the first things to clamp down, right? You don't need to be digesting food when you have severe shock to your heart and brain, right? We're going to reroute blood automatically with our SNS to our core, right? We're going to shut down the periphery, get cool clamping extremities, and we're going to reroute blood all the way to the brain, coronaries, the lungs, and skeletal muscles for that matter. And all these things are going to get that flow of blood, hopefully, right? So the gut is going to suffer in that situation. So this being said, your surgery cases, especially your GI surgery cases, they hate it when you start pressors. So you definitely want to let a GI surgeon know that you're starting pressors, because it's not going to let their wound or their intestines that they anastomose together, they sewed together, it's not going to heal great if it doesn't have the blood supply, right? So how do you prevent that? You don't make them NPO, so you feed them, right? If you put a little bit of trickle feeding, you just tickle the bowels on the way through, like just 10 mLs an hour of feeding, that's going to keep the bowels alive, keep it peristalsing, and keep it getting blood flow, right? While we work on the more serious situation in the core, we're going to still let the gut get some kind of flow, right? Some kind of nutrition. But ironically, the GI surgeons say keep them NPO. So, okay, well, which one do you want, right? Do you want pressors, or do you want, which one are we doing? Yes?
Yesterday you said that radial art lines overestimate the core blood pressure, so a map of 70 sometimes is better.
Yeah, so you can, if you definitely have a low pressure, having a little higher map target for A lines can help. Because yes, a radial A line is reflected information, right? The aorta gives off a systolic peak and a diastolic peak or notch, and then that's going to be reflected throughout the periphery. So a map of 65 is really like a map of 60, right? So having, that's something to consider as well, right? So sometimes they say, oh, just do the map of 60. It's like, well, really that means I'm doing a map of 55, right? Because it's going to be off by about 5 to 10 points. So yeah, so that's a good point with art lines, that they a little overestimate a little bit, but not as much as overestimation as your NIBPs, right? They're a lot more accurate. Okay, so what else? So you get poor peripheral perfusion when you have a shock state, as we mentioned, right? But fluids usually are given first before we start pressors, with a big asterisk, right? If they are end-stage renal disease, CHF, really it's not a great idea to load them with more fluids. But if they're like a septic shock patient, definitely we're doing some fluids first before we do pressors, right? You don't want to have a dehydrated patient, like a hypovolemic patient or a trauma patient, and then not have given fluids or what they need, like blood and hemorrhagic shock. So giving fluids is a good idea. And we have certain criteria like 30 per kilo for our for sepsis, but sometimes we're not going to give more than 2 liters. That's usually a good cutoff, right? Before we say that we gave it a shot, right? Blood pressure is still low, and I gave 2 liters. That's probably not going to respond to another liter. It's time to get to initiate pressors at that point, right? Everyone can tolerate a 250 bolus, right? You give a 250, you could give a 250 on the house and see if that helps the blood pressure, right? Before you can get a hold of the provider, maybe like an RRT situation, or even an ICU situation where the ICU doc is busy, intubating, do another situation, another room. 250 is not going to hurt, but you can give a free 250 by just raising their legs. Passive leg raise, right, will raise their blood pressure. Should be if they're responsive to fluids. But laying them flat, of course, one of our first steps, right? So it's a modified Trendelenburg. You don't want to do it too much, otherwise they'll have the bradycardic response. So you want to make sure it's just a modified Trendelenburg, and then you modify it some more and raise the legs up. You get a little passive leg raise. That won't work if they have ascites or a pregnancy or a huge belly. That's not going to be the fluid is not going to reach the heart at all. All right. Yeah, 30 mils per kilo is usually too much, right? If they're young patient, sure, right, that might work. Okay, and you can assess the response to fluids, see if the blood pressure improves, see if your numbers improve a little bit, but definitely you're not giving more fluids if you have crackles, right? If you have a patient that's severely edematous, and you can argue that an edematous patient is intravascularly dry, so maybe albumin might be a better drug in that situation. But either way, the end game is always pressors. That's what we are looking at. So our end game is starting vasopressors, and we have to look at the response to the pressors. So we know that titrate MAP at 65 is a good target. And we can look at heart rate, because some of our pressors can cause heart rate elevation, right? They can cause a tachycardia because that's just their direct effect, right? Like dopamine causes tachycardia, epinephrine, tachycardia, right? It's just off the bat, it's going to cause that. Norepinephrine is at high doses, it'll cause tachycardia. Low doses, it won't. Right, we're doing blood pressure checks. We're making sure every 5 minutes, especially a really sick patient, but minimum every 15, right? Every 15 minutes for a patient that you're actively titrating. That's a sicker patient. If they've been on leave-fed for a good 12 hours, every 30 minutes it's okay. That's fine, but definitely not every hour if you're on pressors or sedation or an infusion of medications. Every 30 minutes is a good stopping point. But if you're actively moving medications back and forth, they just came to the ICU, every 15 minutes is usually a good ballpark. But you might have to even do it every 5 minutes or even 3 minutes or Q1 minutes sometimes, right? And you know that an NIBP is going to overestimate that blood pressure if you're doing Q1 minute cuff pressures, right? Those pressures for those 5 minutes are going to be escalated because the blood is pooling in that situation. Right, lactate's going to let you know if we need to add more pressors, or if they're responding to pressors at all. Lactate keeps going up and up and up, then that means that they have another situation happening. Maybe they have an extremity that doesn't have perfusion, or they have a gut that's dying. That could be a reason for the shock state, but also it might be a reason that we have to get source control. Okay. And then assessment, cap refill. Sometimes I always forgot it in my first 1 or 2 years. Oh yeah, cap refill, 3 seconds, I bet, right? Or they had poor perfusion. I bet it was more than 3 seconds. But it's actually validated. It has a lot of validation as a tool to assess someone's perfusion. If cap refill is poor, you can say that it is they do have poor perfusion. So it has a lot of evidence behind it. And then modeling, as we mentioned, the model of the knees is a good indicator that more pressors won't work. And also it's an indicator that the body is really shutting down. And then hemodynamics. So we talked about hemodynamics, right? Your cardiac output, your PA pressures, your CVP, your SVR. We have a little caution because sometimes we do what are called designer hemodynamics or monitor cosmetics. Like, look at my cardiac output, look at my SVR, look at my heart rate. Everything's perfect, but is it perfect for the patient? Because now they're on like 3 medications, right? Oftentimes a more experienced person can come in, they're going to stop it all and wean it all off. And yeah, the cardiac output might be like 2.5. The SVR might be 1400, but they're fixed, right? They don't need any drips, right? So there's that danger where we overutilize the numbers because you just want the numbers to look good. Okay, so CVP has some utility, but not for giving more volume. You can say if they're too much volume, CVP is going to be high, right? So you hook up a CVP and CVP is like 16. It's like, yeah, it's time for pressors, right? Giving 250 EVA is not going to help that patient, right? A-line, as you mentioned, it has a lot of utility as far as its width and its narrowness, right? Whether you're dilated or not, right? If you're super, super dilated, give more fluids, it's just going to leak out anyways, right? 95% of the fluids we give, like normal saline and LR, 95% of it is just going to leak out anyways, right? You're only 5% of that's going to actually stay in the bloodstream. Okay, so lactate will tell you if you have good perfusion, so it's a good idea to get lactates in the morning for morning labs to see if we're going the right direction, right? If it was trending down, maybe every 2 days, but it's a good idea to see if that's getting better or not, right? Urine output is good, right? But again, it's you have to get an hour's worth at least. So that's a kind of over time. You can see what the urine output was the last 24 hours, and then you see the urine output improved. That can tell you have good perfusion to the kidneys. Sometimes it doesn't improve, so we have to figure out what else we can do to kind of get the kidneys reperfused. Okay. So pressors and receptors. So to recap on the pressors, recap on the preceptors, recap on the receptors that we talked about with hypertension and CHF. All right, so these guys are, our adrenergic receptors. So why is it called adrenergic? Because it's adrenaline goes there, right? So adrenaline goes to the adrenergic receptors. So what's adrenaline? That's epinephrine, right? The nerve form is norepinephrine. So that's norepi and epi. So norepi and epi gets released, right? Where does it come from? Adrenal medulla, right? So it's specifically the nougat center of the adrenal glands, right? That's where norepi and epi gets released into the bloodstream. And it's going to go through the bloodstream, and it's going to attach to what? To our little beta-1 receptors and our alpha-1 receptors, right? So in this case, it's an example of an alpha-1 receptor. So over here, we got norepinephrine attaches to our alpha-1 receptors, right? So alpha-1 receptors are located where?
The periphery.
They're in the blood vessels, so are beta-2 receptors, but they are located specifically, yes, in the periphery, but they're located in the GI, skin, and renal arteries, or arterioles specifically, right? So our alpha-1 receptors are in our GI, skin, and renal, right? So alpha-1, it's going to vasoconstrict when it goes there. So that norepi and epi is going to go through the bloodstream, and it's going to attach to different receptors. If it attaches to an alpha-1 receptor, it causes vasoconstriction. And specifically where alpha-1 receptors, those are on the GI tract, which is the largest organ system in the body, right? We're going to reroute blood away from the largest organ system in the body to more important areas, right? So like when you run away from a bear, you don't want to be resting and digesting. You will have diarrhea, but that is just a response like, get out of the way, and I need to run, right? And then after that, the GIs gets constricted and the renals get constricted. They're not going to like that, right? The renals like to have a lot of great flow. So they're going to start doing their own thing, releasing renin in the RAS system. But the other piece is GI, skin, and renal. So the skin is the largest organ system on the body, right? So that's why we're going to reroute blood away from the skin. We get cool skin, right? And you happen to have receptors or adrenergic receptors at your let's take the acetylcholine receptors on your sweat glands, so they get cool and clammy, right? So we release all that norepi, and that's going to bind to those alpha-1 receptors and cause widespread vasoconstriction. On the beta-2 receptors, it's going to vasodilate, right? It's going to vasodilate the coronaries. It's going to vasodilate the bronchioles, and it's going to vasodilate the skeletal muscle, because we want that blood flow to those areas. Again, if we're running away from a bear, or we are, trying to save our own life we have a sepsis process, right? We want to reroute blood away from the periphery and go to the core, right? To get a good blood flow to our coronary vessels, our pulmonary vessels, and to our skeletal muscle. All right, so that's what beta-2 receptors are involved with, right? Vasodilates. So norepinephrine just going in the periphery, and based on what receptor it lands on, it's going to do its thing, right? So it has different effects on different receptors. So what else happens? So if you're running from a bear, you want energy, right? So you can continue running away from the bear. So glycogenolysis is a effect of beta-2 activation. You activate a beta-2 receptor on the liver, you're going to get the glycogen stores broken down into glucose. So now your sugar is going to go up. We know the SNS fires off when you have low sugars, and that's one of the ways it can fix it, right? So when you have a low sugar, you have norepi and epi are going to get released. they're going to go ahead and go through the whole body, and you're going to get symptoms, right? So that you can figure out you need to eat. You're going to get tachycardic, tachypnic, you're going to get super sweaty when you get hypoglycemic, and you're going to have a feeling of impending doom. You're going to get really anxious, you're going to get really hangry, right? And you're going to then hopefully consume some calories. But in the meantime, your body is going to react and start making glucose for you as well, all right? So that's a situation, but also how else do you make glucose? You can also go to the testes of the brain, the pituitary gland, and you can have it secrete ACTH. And ACTH is going to come down and release cortisol. And cortisol is a glucocorticoid, so it's going to raise your glucose, right? But also, what does it do? It also stimulates, it's anti-inflammatory, right? So it's like, hey, I got stabbed, right? So I want to reroute blood away from the periphery, right? We know that's probably a good idea. And also, might be a dirty knife, right? It's probably not a sterile knife from surgery, although it could be, right? So you want to make sure that you're fighting off any kind of invading bacteria. And that makes sense. I want cortisol around so that it's going to be anti-inflammatory in case something is going to start causing a sepsis process, right? And cortisol actually primes all of the adrenergic receptors as well and gets them receptive to more norepi and epi, right? So we find in more advanced shocks that we give you're on a really shocky patient, hypotensive, you're on Levophed at 10 mics, 20 mics, you're on norepi, you're on vasopressin, you're on your two pressors. What else can we do? We can add hydrocortisone, a glucocorticoid that will prime your receptors and help your blood pressure out, right? So cortisol is an important part of the story as well. And then going back to beta-1 receptors, right? So beta-1 receptors respond to the SNS. The SNS releases norepi, right? And they can attach to beta-1 receptor. It's also going to release norepi at the adrenal medulla and release epinephrine in circulation so we can maintain that response, right? And what happens to beta-1 receptors, though? So beta-1 receptors, you're going to get a rise in your heart rate and your contractility on the heart. That's where beta-1 receptors are located throughout the whole body. But on the heart specifically, you're going to increase heart rate and increase contractility. That's also known as inotropy, right? Is contractility, heart rate is chronotropy, right? You're going to increase those things with norepi or epinephrine or an SNS response. And then you also have beta-1 receptors right there on your kidneys, all right? And you're going to specifically at the juxtaglomerular complex. So the JG complex releases renin, and now we're on a cascade of the RAS system, right? So our RAS system is firing off, and that's going to do 2 A's, angiotensin, right? So it's going to tense angios. You're going to have some vasoconstriction in that regard. And the second A is your aldosterone, and that's going to raise my blood pressure as well. How is aldosterone going to raise my blood pressure? Stopping secretion of sodium. So it's going to inhibit the sodium-potassium channel in the kidneys, right? So you're not going to get rid of any more sodium. Okay, pump the brakes. We need that sodium. We're going to keep the sodium in the system, and we're actually going to exchange for potassium. We're going to excrete potassium. We're going to keep the sodium behind, and water is going to follow, and that's going to restore volume or preload, right? So the RAS system restores preload and also restores, it increases afterload. It vasoconstricts as well, right? So that's beta-1, right? And also, if the RAS is fired off by itself, it's going to stimulate the SNS. So it's all an intertwined system. The only hormone we're missing is vasopressin, right? So not only does RAS stimulate vasopressin release, but so does the SNS, right? All these guys are going to go to the pituitary, and they're going to say, hey, you want to come out and play? Or we got some vasoconstriction activity out here. And what does vasopressin say? I like to press vasos, right? So it's going to come out and it's going to vasoconstrict, right? So that's its thing. And we'll talk more about vasopressin because it also increase preload as well, right? It acts on V1 receptors and V2 receptors at the tubules, and it's going to make them reabsorb water, so that free water, so that you're going to restore your blood volume as well, kind of like aldosterone's doing, but on a different molecule. Aldosterone absorbs sodium and water follows. ADH or vasopressin is antidiuretic hormone. It makes you not diurese. It's going to absorb urea, and water is going to follow urea. So that's how vasopressin is going to get involved. So these are all your kind of receptors. We got your vasopressin receptors. We have, because vasopressin doesn't land on beta-1 receptors or alpha-1 receptors or anything other receptor. It lands only on vasopressor receptors. So vasopressin gets released, and then it responds, it binds to vasopressin receptors. That's what it does. And when you attach to a vasopressin 1 receptor, it causes vasoconstriction. You attach to a vasopressin 2 receptor, which is only located in the kidneys, the kidney tubules, it's going to reabsorb water, right? And then angiotensin 2 lands on angiotensin 1 receptors. Remember, they don't want to admit that they're wrong, right? So angiotensin 2 binds angiotensin 1 receptors. It's like, should that be 2? No, we already published the article. You can't take it back. The textbook's already out in print. They already spent $200 on the textbook. What are you talking about, right? So that's yes, it binds on angiotensin 1 receptor, and when that happens, right, you're going to get vasoconstriction. That's what happens when you bind to an angiotensin 1 receptor. Okay, so these are all the interactions that occur with our body's natural response. So what we have in our arsenal is we do have angiotensin 2. We have vasopressin or as a medication. We have norepinephrine as a medication. We have epinephrine as a medication. And we have the precursors to our norepi and epi. What's the precursor to norepi and epi? What are the building blocks of norepi and epi? What are they formed from? Dopamine, right? So dopamine is, this one right here, dopamine is a precursor to norepi and epi. So if you give someone dopamine infusion, you're going to get a rise in your norepi and epi, and you're going to get the activity that you want, the SNS activity that you want, right? So these are the different receptors involved. Another little piece is your alpha-2 receptor. So your alpha-2 receptor is the off switch for this whole thing, specifically at the vessels, right? So if you want your vessels to relax again, right, norepi gets released and it causes vasoconstriction, but it's also can come back around and inhibit the release of itself, right? So it's kind of self-regulating. So when we talk about hypertension, when someone's on the flip side, someone's super hypertensive, we can give alpha-2 agonists, and that will lower someone's blood pressure, like clonidine, for instance, an alpha-2 agonist. All right, so those are our different receptors. So we'll kind of touch base again on V1, V2. We'll touch base on our alpha-2, yeah, technically, but alpha-1, beta-1, beta-2, and of course our little dopamine receptors as well. All right, so norepinephrine, it's our first Avenger. That's our first one we're going to use, and that's the one that's going to do its thing, right? And what is SNS's thing? Yes, there's norepi, yes, there's epi that SNS releases. We're given the norepi piece. And what does norepi do? It binds to your alpha-1 and beta-1 receptors, but there's a little unique property about it that it binds the alpha-1 more preferential, right? So it'll bind to the alpha-1 receptors, which are located where? Peripherally with the GI, skin, and renal, right? So it's going to bind to those GI, skin, and renal arterioles, right? And it's going to vasoconstrict them, right? It's going to respond to those vessels, and it will vasoconstrict that vessel there, right? So we got the norepi being released in the bloodstream. It's going to do its thing. It's going to bind to alpha-1 receptors right there. So every one of these slides has a picture of a table with everything, has a little summary, and a picture of how it works, right? So here's our norepi we're talking about. So norepi is going to bind to alpha-1 receptors. And then eventually at higher doses, like 20 mics, 25 mics, it's going to start having beta-1 activity. And what happens when you attach to a beta-1 receptor? Increased heart rate and contractility. So you will get some inotropy, cool, that's neat, but then you're also going to get some heart rate elevations. Your patient all of a sudden go to AFib RVR or have VTAC or have PACs and PVCs. I can't figure it out. It's because you're on Levophed at 25 mics. That's why your patient has these symptoms, right? So beta-1 is on the heart, right? You have one heart and two lungs, right? So beta-1 on the heart, beta-2 is on the lung arterioles. It's also on the beta-2 is also on the bronchioles to help bronchodilate as well, right? So alpha-1 greater than beta-1. So first, 15, 20 mics is definitely alpha-1 activity. And then it's going to switch over to beta-1 activity, all right? And you can't even get beta-2 activity at high doses. What is beta-2 activity?
Of airways?
No, beta-2 is good. Beta-2 dilates, right? Beta-2 is going to dilate the pulmonary arterioles, and beta-2 is going to help. It will also increase your blood sugar a little bit, so you might get some hyperglycemia when you have really, really high doses of Levophed, right? So this dosing right here is what you get from corporate, right? So that's your start date, start time, your max, your min, right? So all that is by default what you're going to see.
So high doses it starts acting like epi?
Pretty much, yes. Norepi at high doses is kind of similar to epi. Okay, epi is going to be like pure epi all the way, right? And then what else? Side effects, again, cause tachyarrhythmias at high doses, right? and you need to give it via a central line, right? It's usually our first agent, so oftentimes they don't always have a central line initially. Do you have to like wait for the central line? No, it is safe for a good 8 hours or so at lower doses, but once you start getting more than 10 mics, it's probably time to get a central access. And they say, oh yeah, if the peripheral IV is in a vein that's greater than 4 millimeters, then you're good. It's like, who's measuring 4 millimeters? Who knows if that vein is 4 millimeters or not, right? If it's ultrasound guided, probably it's going to be a bigger vein, right? If it's like a midline on the upper arm, that you can maybe get away with that for another 12 hours or so. But still, if that's the walls of the vessel are not that thick in the arms, right? So you need a thick vessel in the femoral vein or the jugular or subclavian. Okay, there's different concentrations. Usually 8 is where we start most of our patients, right? And then if they're really, really fluid volume overload, we might go ahead and double concentrate it to 16. All right, so how do you turn off norepi? So norepi binds alpha-1 receptors, and it's going to turn itself off. Do we want that when someone's in shock? No, but that's just how the mechanism works. The alpha-2 receptors are an off switch for your norepi naturally. But our norepi is the bee's knees. That's the one that everybody gets started on. That's usually our first line agent for every shock. All right, so vasopressin. So vasopressin is the BFF. That's the one that's going to be working synergistically with norepinephrine. And we know naturally that when norepi gets released, the RAS, of course, fires off, and the norepi and the RAS are going to trigger the ADH, or vasopressin, to be released, right? And again, we're in witness protection with vasopressin, right? So we got ADH, vasopressin, DD-arginine, vasopressin, we got desmopressin, we got arginine, vasopressin, we got argipressin, right? But so it's just vasopressin, right? And it makes sense it should be called vasopressin because it binds to vasopressin receptors. So I think they already kind of sealed the deal. But if you go to Australia, they call it argipressin. You go to across the pond to Europe, they call it desmopressin. So kind of, you just say, guys, it's vasopressin now. It doesn't make any sense. You're just confusing people. They're trying to learn ICU. All right, so yeah, so we have, the SNS is definitely going to trigger vasopressin to be released, and so will angiotensin 2, right? And they're going to bind to V1 receptors and V2 receptor. Which receptors are on the tubules? V2. And they're going to bind to those tubules, and they're going to raise preload. How do they do that? They go right there to the tubule, the distal tubules of the nephron, and they're going to promote the absorption of urea. So urea is a osmotically active molecule, right? Just like where sodium goes, water goes, where albumin goes, water goes, where glucose goes, water goes, and where urea goes, water goes. Also where E2H goes, water goes too, right? But we don't have a receptor for E2H, unfortunately, right? So but urea is going to go into the bloodstream, right? So this vasopressin gets released when you have SNS and angiotensin 2 activity, right? And it's going to reabsorb water, and increased water is going to raise our preload. And then also, your BUN is going to go up, right? So that's why in pre-renal failure, when someone's dehydrated, when someone is shocky, you're going to see a BUN creatinine ratio where the BUN is higher than the 20-to-1 normal. Okay, so what else? So we have it's our adjunct to norepi. Its action is pure vasoconstriction, and also it's going to raise preload. If we vasoconstrict, what's that going to do? Is that going to increase preload, afterload, or contractility? Afterload. Yes, it does increase preload, but our primary purpose of this is to increase afterload, vasoconstrict, and constrict those peripheral vessels. And it's like really all vessels start getting vasoconstricted. All right, so the dose, right? We mentioned there's a fixed dose and there is a titratable dose. The fixed dose is just 0.03. That hasn't changed in many, many years. I've seen it once at 0.04, but usually it's 0.03 is the usual fixed dose, and that's the dose for septic shock. And then after that, we have titratable doses. So really, you should not be on titratable doses because what's our most common shock is septic shock. Like at least 60% of the time we have septic shock, you should be on a fixed dose of vaso, right? And you really should be on vaso by itself, all right? You should be on norepi vaso, and then you take away the vaso, and the norepi then it kind of is titrated off, all right? But you sometimes do need to have a titratable vasopressin when you have a hemorrhagic GI bleed, right? You have a GI bleed that's bleeding and bleeding and bleeding. Like, yes, vasopressin is going to cause gut ischemia, but at least either they survived, right? And we stopped the bleeding because that's a little more serious in that situation. And that's where you hit a titratable max of 0.1, not 1. 1 is 100 times or more potent, right? So please don't go too high, much higher than 0.3, 0.03, right? 0.03, starting at 0.01, I should say, is the max, right? And our side effects, well, very, very minimal. You could get hyponatremia because you're retaining all this free water, but it's quite uncommon for that to happen. All right, so epinephrine. So epinephrine is our norepinephrine, right? So norepinephrine are really the same thing, but they do have epinephrine has a little more activity than norepi does, right? Epinephrine can do all the same things that epinephrine does. So I did point out on the previous slide, but the table for all the different drips is there. You can see your dopamine, you can see your vasopressin, you can see your norepinephrine and epinephrine. So you can see your epinephrine has 4+ activity on the alpha-1 receptors, right? So it's just like norepi. Norepi is all about vasoconstriction. But you can see that the beta-1 activity, yes, you get some with norepi, but epinephrine just starts full strength, right? Because epinephrine is not going to be like norepinephrine, because norepinephrine was alpha-1 then beta-1. Epinephrine is just both at the same time. You get alpha-1 and beta-1 at the same time. Alpha-1 is the vasoconstriction at the GI, skin, and renal, and then the beta-1 is going to be the heart rate, right? The heart rate and contractility is going to increase. So it's going to increase heart rate, and it's going to increase contractility, right? So beta-1, that's side effects, but you have your, it's literal SNS in the bag, and it's going to definitely increase your heart rate, cause tachycardias, cause tachyarrhythmias, but not as bad as dopamine. So it's going to be like a more natural SNS response that you're providing to the patient, right? But you got to be alert if you're starting a patient that is tachycardic, because it can make the tachycardia worse. Sometimes it might be what they need, right? They might need inotropy, and that's what they need. And then once you fix the inotropy, the heart rate might go down. Okay, so your beta-1, beta-2, and alpha-1. So beta-2, though, does norepi do beta-2? Really, really high doses, it might do it. But what is beta-2? Because epinephrine definitely does beta-2 right out the bag, right out the gate, right? So you give epinephrine, you got beta-1, alpha-1, and now beta-2. So what do we do in beta-2? What happens when you stimulate those?
Relaxation.
So bronchial relaxation for sure, so they might breathe better, but also we're going to dilate not the peripheral, but the pulmonary vasculature. You can see it's a 1-, so it's really going to vasodilate out that pulmonary vasculature. Yes, it's going to raise your systemic vascular resistance, right? So I probably get rid of that one, but it's definitely going to decrease your PVR. It's going to decrease your pulmonary vascular resistance. So someone who has what kind of failure would need to have this? Respiratory failure, yeah, but also definitely someone who has some right heart failure, right? As long as it's not, due to like left heart failure. But then also this can help left heart failure. So it's actually great for both, but best for someone who has some pulmonary vascular hypertension, right? Some pulmonary hypertension. And really, this is one of your last ditch. You're throwing the kitchen sink. You're throwing everything at the patient. Right? This is where like one of your third pressors. You started norepi, you started vasopressin. Let's add epinephrine on top of it. And if they find like hey, they did an echo and the EF's only like 10%, well, now I got 2 medications. I got dual titration. I got norepi and epi. I'm going to come down on the norepi and I'm going to come up on the epi, right, to help with the inotropy. I know if I go way, way high on the norepi, I'm going to cause some inotropy, but maybe I don't want to have too much of the side effects of norepi, which can be what? What are the side effects of too much norepi? Too much norepi, you're going to start getting beta-1 activity, which will cause what? Increase heart rates, right? Really, its deal is all about the alpha-1 receptors. And epinephrine, yeah, it does alpha-1 receptors too. It does beta-1 receptors right out of the gate, and it does beta-2 receptors, right? Also, beta-2 receptors are found on your liver, and you're going to get glycogenolysis, right? And you're also going to get lactate production, because lactate we know is protective when it's 2 to 4. It's like a fuel for your heart when it's in a hypoxic state. So when someone is on epinephrine drip, you're going to get a lactate, and they're going to say, oh, lactate's 6. It's like, well, that's because they're on epinephrine drip. That's why it's gone up, right? And same thing, that you're going to expect the sugar to go up when you're going to start an epinephrine drip. So the sugars are already like 200s. You should probably ask for an insulin drip as well, because they're definitely get hyperglycemic, guaranteed with epinephrine. Okay, so hyperglycemia is a side effect. And should I give sub-Q insulin coverage if I'm on an epinephrine infusion? Why is that? Why do I need IV, not sub-Q?
Because you're constricting, so.
Yeah, I'm vasoconstricting all this stuff here, right? And where does insulin get given? I get a little shot of insulin and it just sits right there. Am I going to absorb that? No, right? So they might absorb it later when they get out of the shock state and think, whoa, they got hypoglycemic. But in the meantime, we're not going to get good glucose management, right? So IV insulin is what you need to give it directly in the vein so we can get a sugar under control, right? What else? So epinephrine, you do give epinephrine and ACLS, like for PEA, VFib, VTAC, but it's 1 milligram you're giving. You're giving this whole dose of 1 milligram. And when you get a bag, it's 5 milligrams. So someone says, oh, I shouldn't give a dose of epi. They're already on epinephrine infusion. Well, that's 5 milligrams and 250, right? It's going to take a while to get 1 milligram. If it's 250 cc's, that's like 70 cc's I have to give before I even give 1 milligram, right? So it's not the same, right? So there's such thing as push dose epi, and you can be giving push dose epi while you're on an epinephrine infusion, right? That's legal. But so it's just something to consider when you have a patient that is getting a lot of drips and they're about to code. You can still give push dose epis to support their blood pressure. All right, what else? So that's our story on epinephrine, right? It's great for patients that have increased PVR, patients with pulmonary hypertension. All right, and then dopamine. All right, so dopamine we're just going to cross out because we don't use dopamine, right? But dopamine does have a trimodal effect or even a bimodal effect. At low doses, it is going to vasodilate, and they even vasodilate the kidneys. They're like, oh, let's give renal dose dopamine. If anybody says renal dose dopamine, you got to slap them immediately because that's not a thing, right? That's been, yes, it does increase urine output, but it's not beneficial, right? And then once you get over 5 mics, you're going to start getting some vasoconstrictive properties. And then over 10 mics for sure, over 50 mics, you're going to start getting that vasoconstrictive properties, right? So it has this bimodal appearance. So in the low doses, it vasodilates, and the high doses, it vasoconstricts. If someone wants to do a dopamine, it's like, oh, just start it at 4 mics because the blood pressure is low. It's like, that's going to make the blood pressure lower because that's going to vasodilate, right? So how about we start it at 10 mics, right? So you can see our thing says start at, it should be 5 to 10 mics. I think our initial says 2 mics. I'm not sure if that's changed recently, but starting at 2 mics for hypotension does not make sense, right? And those that haven't taken this class, they're going to do exactly what the order says, right? And that's going to worsen their outcomes. All right, so make sure we're starting at at least 10 mics, especially if they're hypotensive, if we are going to be doing this, right? And there are specific dopamine receptors throughout the body. There's a lot of dopamine receptors in the brain, right, for reward and for movement and such, but there is dopamine receptors like on the kidneys. That's why you get some vasodilation. And eventually dopamine receptors get saturated, and then you start providing the precursor to norepi and epi, because you notice dopamine's all the way up here, right? And what's next in line in the cheese factory is norepi and epi, right? So those guys will be increased a little bit as well. And dopamine, why is it so bad? It's very, very tachyarrhythmogenic. It causes a lot of tachyarrhythmias, VTAC, PVCs, a lot of tachycardias, AFib, RVR, PSVT. So that's going to worsen someone's outcomes because you have to start another medication to support their, to fix that arrhythmia, or that arrhythmia might be causing hypotension, and then we're back to square one. Okay, and phenylephrine. So what is phenylephrine? Phenylephrine is a direct alpha-1 agonist. It is pure. It is only going to go to alpha-1s. Absolutely, there's not like a high dose, low dose, medium dose, backward dose where it causes some tachycardia. It's impossible. It only binds to alpha-1 receptors, right? And alpha-1 receptors are located in our GI, skin, and renal, so it only clamps down on those, right? That's its only one and only thing, right? So phenylephrine is alpha only, pure alpha. Norepi, a lot of alpha, not so much beta-1, whereas epinephrine is all 3. Right? What did dopamine? Dopamine will do dopamine receptors, but eventually we'll start creating some little norepi and epi on a downward stream. And we'll talk about dobutamine later, but we have phenylephrine is our alpha-1 only, right? So it's only going to vasoconstrict. All right. So the doses, it's dose per kilo. And what are our side effects? If we get too high of a phenylephrine, right, you vasoconstrict way too much, blood pressure is now 160s, 170s. The SS is like, whoa, that's way too much squeeze. I know how to fix that. I'm going to go away. All right, so the SS is going to go away because the baroreceptors are being overstimulated, right? So they're going to then cause a reflexive bradycardia. So that's one of the side effects if you have too much phenylephrine. Okay, so vasopressin, yes, it has gut ischemia, and vasopressin is just vasoconstriction. Vasopressin is similar to phenylephrine in that it has no effect on the heart rate, right? Vasopressin just squeezes vessels. Angiotensin 2 just squeezes vessels. Phenylephrine just squeezes vessels. That's all it does, right? So what is it? Phenylephrine used to be in Sudafed. They did a big study recently showing that it has absolutely zero effect on someone with people with Sudafed and controlling controlling the nasal congestion. It makes sense physiologically, right? If I vasoconstrict, it's less leaky, therefore I have less drainage, right? Less nasal drainage, but it doesn't work. It just causes you to, it's just a substrate for meth, right? That's all it is. That's why I have to use your ID when you buy Sudafed. Like, what the heck? It's because people take it and start making meth out of it. Meth is a sympathomimetic. It's similar to direct SNS stimulation, right? But neosynephrine, when is it good? I mean, it's not great as a first-line pressor for a few reasons. Yes, it's going to vasoconstrict, but norepi and epi, if you look back at norepi, it actually stimulated the anti-inflammatory cascade, right? It's similar, it stimulates cortisol release, it's more anti-inflammatory. So someone is in septic shock where they have too much inflammation, it makes sense to give norepinephrine, which is going to help with that inflammation, right? Neosynephrine does none of that. It just goes in, does its job, and says, where do I go next, right? So all it's going to do is vasoconstrict. So it's really great like in neurogenic shock, right? So neurogenic shock is just lack of SNS activity. What makes this to replace norepinephrine? You're not going to be wrong. But what else causes just vasodilation would be like sedatives, right? So every sedative causes vasodilation. So we're going to have a vasodilation situation when someone's gotten sedative from anesthesia. Anesthesia often has neosynephrine in their pocket. They're going to give a little push dose of neosynephrine so they can make it from the OR over to ICU. And all of a sudden they get to ICU and the blood pressure's low. What the heck? What happened? You're like, what did you give? What did you give? And it's just, shh, I didn't give anything. Nothing happened, right? But coming to find out, yeah, the neosynephrine was pulled from the pyxis. You're like, aha, I caught you, right? So that's, you got to ask them. You got to get in the corner, sit them down, get the hot light on them, and hey, what'd you give, right? So then you realize, oh, I should probably start a pressor then, huh? Right? I should have had that ready. You should have called report and told me to get some norepinephrine ready or phenylephrine ready, right? But they usually have that just on standby just anyways. It's a good practice because if they're giving sedatives left and right, they want to have something to reverse it, right? To reverse the side effect. All right, so that's the idea behind neosynephrine or phenylephrine. All right, other agents we might use. So this is where like you're starting to get, start to like push up your glasses like Mr. Smarty Pants. You're like, you know what? I know how methylene blue works. Methylene blue is going to actually work on this thing and that thing. That enzyme is going to actually reverse this and reduce the free radicals. And we're going to have some increased camp activity. Cool, right? So methylene blue is like an agent that we have plenty of, right? There's so much of it around. So it is going to vasoconstrict, and it's going to vasoconstrict really great, right? So that is another agent we can use. And there's a super pricey one, all right? So if you have a lot of money, then yes, you could get angiotensin 2, which is again like $1,000 to $2,000 per bag, right? And you're changing the bag every like 4 hours. And the pharmacy's like, no, we're not doing that, right? So that's it is an option out there. So if we do get that, I think it's GeoPrezza is the brand name, which is a great brand name. Sounds like I want pizza tonight, right? So GeoPrezza, right? So like 30 minutes where it's ready. All right, so we have pure angiotensin 2, which makes sense, right? If we ever do get it, we just kind of fit it. Oh yeah, it's working right there. It's going to vasoconstrict purely, right? Methane blue is an option as well. And then now we're going to start, adding some other things that are going to increase inotropy. Because when you increase inotropy, yes, epinephrine and norepinephrine do increase beta-1 activity, and we have our contractility increased, right? These are called inopressors. They vasoconstrict and they increase contractility. But we have other medications that increase contractility, but they are inodilators, right? So we have inodilators over here, dobutamine and milrinone, which are great at increasing contractility, increasing cardiac output, but they're going to vasodilate, right? So someone has cardiogenic shock, we start usually norepinephrine. We might start epinephrine a little later, but definitely eventually if they're going to sustain, they're probably going to need dobutamine or milrinone to help out. And we have a slide dedicated to these guys. Okay, this is our overview slide, right? Looking at dobutamine, milrinone, and isoproterenol. These are inodilators. And then we're familiar with our vasopressin and phenylephrine. Is there any kind of beta-1 activity? Absolutely not. All they do is vasoconstrict. So they're not going to increase the heart rate. And they're also not going to increase inotropies. They're not called inopressors, they're called just pressors. So truly vasopressors, the only two vasopressors we have are vasopressin and phenylephrine. And if you're fancy, you could get your other two there, methylene blue and angiotensin 2. But then we have inopressors, right? So this is a more accurate way to describe our pressors, right? We have inopressors, they're going to increase, they're going to vasoconstrict, but they're also going to increase, yes, heart rate, but they're also going to increase contractility. So we got norepi and epi. And we have dopamine, right? And dopamine has 3 different levels there, but we're going to cross off dopamine because we don't like dopamine, right? So that's another option out there. So if you have an older provider, you have someone that's, maybe you're starting like the 4th pressor, 5th pressor, sure, let's give it a shot, right? But it's not going to be our first line ever, okay? There's another way you see some places, like dobutamine has a lot of beta-1 activity, not so much alpha activity. Epinephrine and norepinephrine have a lot of beta activity and a lot of alpha activity. But look at phenylephrine, pure alpha activity, right? There's another way to look at the same thing. All right, so norepi, great in all shocks, right? All right, phenylephrine, why would we start phenylephrine? If they're in a shock state and they have tachycardia, right? So they have, yes, sedation, but also another reason would be if they have like AFib RVR in the 170s. It's like, well, let's start norepi. So that might raise the heart rate, right? Especially if we get a higher doses. So phenylephrine would be a good option in that case. Okay, and then what up? Vasopressin. That's usually our brother to our norepi. We're going to start that at moderate doses of norepi. Epinephrine, we give an ACLS. You'll give epinephrine infusions with anaphylaxis because it's the job, right? It's going to open up the lungs, right? It's going to stop the inflammatory cascade. So that's a great option as well. All right, and just note that it is going to increase your lactate, right? Someone's like, oh, lactate's 8 this morning. It's because they're on epinephrine drip. There's no reason to fret. And they say your glucose is 400. It's like now you have a reason to fret because you should have started the insulin drip already, right? And it's also going to help the pulmonary vasculature. It's going to help reduce the RV afterload, and it's going to vasodilate those pulmonary arteries and allow better flow through them and also better oxygenation. Okay. And then we got dopamine. We're not going to talk about dopamine. And then we got methylene blue as an option as well. And then we're going to start talking about some of the inotropes coming up.